All right, we're at 7 o'clock, so probably go ahead and get started. Just quickly introduce myself. My name is Dr. Alexandra Cordy. I am a regional director of operations for the Northeast for Community Veterinary Partners. So basically all of New England and a little bit of Jersey, a little bit of New York, hospitals there. So thank you everybody for joining, really appreciate it. I wanna say thank you especially to Merck and Dr. Laura Greene for presenting tonight's VetFuel on the Big 5 canine vector-borne diseases. Dr. Greene earned her DVM at North Carolina State College of Veterinary Medicine and is a diplomat of the American College of Veterinary Internal Medicine and spent several years in specialty private practice before joining Merck Animal Health as a senior professional services veterinarian. Her areas of interest include infectious disease, immunology, and endocrinology, and she has a love of teaching. Dr. Greene's presentation will help prepare the U.S. clinician to recognize and respond to the top 5 canine vector-borne diseases. The epidemiology, etiology, clinical signs, diagnostics, treatment, and prevention options for these 5 diseases will be covered in this presentation. So a little bit of housekeeping, and I'm going to hand it over to Carly before we get started, and then there'll be questions and answers at the end.
Thanks, Dr. Cordy, and thanks, Dr. Greene, for being here, and Merck for getting this presentation up, partnering with us for this presentation. Before we get started, I just want to have everyone, if you can, change your Zoom name to your full first and last name. This will help us with the CE collection purposes at the end of the presentation. So to do that, you can see the directions on the screen. It's whether you're on mobile or desktop, those directions will help you. And that will help us, like I said, toward the end to get your CE to you properly. We are recording this session and we're going to make it available following the live event. In order to receive your CE, you must attend the full live event, however, and we will only be making this available for about 90 days after this session is over. So if you want to take a look at it, you want to do that before the 90 days is up. And lastly, if you would like to submit questions throughout, you can do so 3 different ways. You can send questions via the chat function of Zoom, and we'll collect those for Dr. Greene for the end during the Q&A. You can email those questions to askcvp@cvpco.com, or you can text those questions to 412-400-7447. And like I said, we'll have Q&A at the end. And I am going to pass it off to Dr. Greene now.
All right. Thank you guys so much. Thank you for having me, and thank you all for joining me tonight as we are going to do these top 5 vector-borne diseases of the dog. We've got a lot to cover in 50 minutes, but I wanted to give a little bit of context perhaps for how I look at this particular presentation. So I don't know about you all, but at the end of a long day, if I'm tired, I'm surfing the internet on my phone, and I happen to come across a top 10 list. Let's say something like top 10 deadliest plants. I want to know, what are the 10 plants that made this list? What is it about this vegetation that is trying to take me out? I have to look at this thing. And so it's in the spirit of that kind of top 10 list that I am bringing you these top 5 vector-borne diseases of the dog. And as that implies, there being the top 5 diseases, these are not going to be conditions that you've never heard of. Indeed, I anticipate that many of you will have all too great of a familiarity with these individual pathogens. So what I'm hoping that you're going to gain from tonight is a greater appreciation for how widespread these diseases are, what new areas they might be moving into, and perhaps some bullet points that really help you to talk about these conditions with pet owners in the exam room. Because we all know we only have a limited amount of time to be able to talk about these things, and we need those top things that can really make an impression on our owners so that they're aware of these risks and hopefully how to prevent them as well. So without further ado, I want to introduce you to the brilliant minds who are pictured on this slide. These are the experts who contributed to the creation of every slide you're about to see in this presentation. And you can see each one associated with the disease that they helped to author for those slides. So I feel quite honored to be the conduit through which you're going to be receiving their expertise. Now, a traditional top 10 list typically starts at number 10 and moves their way down to number 1. But we're going to go for it. We're going to just start with the number 1 vector-borne disease of the dog on our list. If we were all in person, I'd love to ask you what you're going to guess that one is. Instead, we're just going to move right on into it. It is everyone's favorite heartworm nematode, Dirofilaria immitis. So why did heartworm receive the number 1 spot for vector-borne disease for dogs? Well, it primarily received that because it has the greatest economic impact on our companion animal dogs around the world. We find heartworm everywhere. It's in all 50 US states, Canada, Mexico. There are dogs in the Galapagos with heartworm disease. Just across the world, we're finding it. And it is spreading into new areas where we had not necessarily seen its prevalence be quite so high before. And there are a couple of reasons for that. One is that climate change is allowing the vector, that mosquito vector, to move into new areas where it was not thriving before. But the other is actually population movement of the dogs themselves. Dogs that were living in heartworm endemic areas, perhaps in the southern United States in shelters, being moved to more northern areas where there's a higher adoption rate for them, and they're bringing that heartworm along with them, which is actually increasing the prevalence of the disease in areas where it did not have such a high prevalence. So we know that the vector of heartworm disease is the mosquito, Aedes anopheles culex. It's all about the same to the heartworm nematode. It does influence a little bit about how far away that mosquito likes to go from its breeding sites. And we know a little bit about what it is that mosquitoes really want in a breeding site. They like warm areas, they like humidity, they need that standing water. And we tell ourselves that, whew, the temperatures drop, it gets colder, we can worry less about that transmission of heartworm disease. And while yes, transmission of heartworm disease does probably slow during the cooler winter months, it is highly unlikely that it stops completely, because mosquitoes are remarkably talented at finding little microenvironments to overwinter. They're settling into burrows, they're potentially settling into homes, and so while you do have that decreased rate of transmission, it never entirely stops. In highly endemic areas, as much as 20% of the mosquito population may actively be carrying heartworm at any given time. So what you see pictured here is the heartworm life cycle, and I'm not going to necessarily go into that in detail because I'm sure you're all quite familiar with it. A couple things that I think are important to point out. If we look at that mosquito in the upper right corner, he is feeding on a heartworm infected dog, and he is picking up those microfilaria. That's the stage he's going to pick up, and those microfilaria are going to develop within the mosquito through their L1, L2, and L3 larval stages. It is the L3 larva that are then transmitted to the next host. And kind of a fun, if somewhat creepy fact, they don't really exactly get injected into that next host. The L3 larvae kind of rappel down the mosquito mouthparts and land on the skin of the dog, and then they just wait there. They wait until the mosquito withdraws, and then they actually migrate in through the wound created by that mosquito. They remain L3 larvae for about 3 to 4 days or so, and then they molt into the L4 stage, which they will remain at for 45 to 65 days. But the key take-home point that I want to emphasize on this particular slide is that our heartworm preventatives, our macrocyclic lactones, are only effective against this L3 and the early part of the L4 stage. And this is why it's so important to talk with owners not only about being compliant, taking home that heartworm preventative, but also being adherent, meaning making sure that they give their doses of heartworm preventative on time so that you're not allowing those L3 larvae to develop into L4, to make it all the way through their L4 stage and into L5. Because once they are a late stage L4, an L5, or an adult heartworm, we are no longer able to stop their life cycle until we consider using an adulticide. And as soon as you have even one adult heartworm, you are causing permanent long-term damage to those pulmonary arteries and to the pulmonary parenchyma. So it's so important that owners understand this isn't a, oh, well, if they develop to an adult worm, I'll just take them out then and it'll be fine. The damage from heartworms can be lifelong. So here's an artist's rendition of those little L3 larvae sitting on the surface of the skin, just waiting to migrate in. And here's what they ultimately develop into. That's the adult female heartworm on top and the adult male heartworm below with his characteristic corkscrew tail. So which dogs are at risk for contracting heartworm disease? And the answer to that is that all dogs are at risk. Certainly there are things we can do to try and reduce the risk of transmission. So you can try to avoid mosquitoes. You can try not to go out at peak mosquito times in the evening. You can try to avoid having standing water where you are. But the truth of the matter is they are everywhere and they're such persistent little ones. I don't know about you guys, but the time when I get bitten by a mosquito is when I'm in the car. Have you been in this situation with me here? Like I'm driving down the road, everything's fine. I've got my dog in the car with me and I'm driving and I hear it. I hear this little, and oh, it's in the car with me. And I can't escape. I can't go waving my arms all over everywhere because I'm a responsible driver. I'm driving down the road. I know I'm a sitting duck. I know that my dog is a sitting duck. There's nothing we can do. That mosquito is just going to be able to have a field day. So avoidance of mosquitoes, not necessarily a good strategy. I've certainly had owners tell me that they think that that's one way that they can do that. It's definitely the best strategy to have them on a heartworm preventative and prevent those heartworms from being able to further develop. If you do have a dog that develops heartworm disease, we classify their clinical signs in these stages, in class 1 being the least affected in terms of clinical signs, maybe no signs or a slight cough and exercise intolerance, all the way to class 3, which is characterized by severe disease. By that point, it is a frequent cough. They are severely exercise intolerant, lethargic, they're losing weight, but they might have that pot-bellied appearance from ascites secondary to right-sided heart failure. And by class 3, you're certainly seeing profound radiographic changes. You're seeing that dilated main pulmonary artery, you're seeing those tortuous pulmonary arteries, and you're seeing those pulmonary parenchymal changes as well. A rare subset of dogs can develop caval syndrome. That's when you have such a chronic infection or so many heartworms that the poor little red blood cells, as they're trying to pass through the pulmonary arteries, are literally getting sheared. They're getting torn as they try to pass through. That results in a hemolytic anemia and severe right-sided heart failure. Typically, caval syndrome can be fatal within 2 to 3 days unless surgical intervention is pursued to remove those worms. Even then, the prognosis can be quite guarded. So how are we diagnosing heartworm? Well, the American Heartworm Society does recommend using both a heartworm antigen test and a microfilaria test. We know those heartworm antigen tests are looking for the female heartworm antigen. So you have to have an adult female to have a positive heartworm antigen test. If you have an infection only of adult males, you can have a false negative test result from that. And then the microfilaria, of course, are just looking for the microfilaria. We're going to look on our blood smear or on a concentration test where we spin down a hematocrit tube and can actually look for those microfilaria in there. Now, sometimes we can get some conflicting results. So you can have a positive antigen test and negative microfilaria. How could that potentially happen? Well, one way that that can happen is if you just have a fairly low worm burden and you're not picking up necessarily on those microfilaria. Another interesting possibility may be the time of day that you're looking for those microfilaria. So they are more active at certain times of the day. In fact, they are most active at those times of the day that correspond with when mosquitoes are most active. So if you have a pet come in first thing in the morning and you look for microfilaria and you don't see them, you may try again later in the afternoon. You might have a better chance of finding those microfilaria at that point. Now, what about if you have a negative antigen test and positive microfilaria? How could that occur? Well, interestingly enough, one of the ways that that occurs is because the dog's body is trying to respond to this heartworm infection, and it is producing antibodies that can bind to that female heartworm antigen. If enough antibodies bind up all around that female heartworm antigen, it is no longer available to bind to our test. And so you can get a false negative. How do we get around that? Well, in cases where you are looking at a dog and your clinical suspicion tells you this dog has heartworm disease. I'm just sure of it. I can't understand why this antigen test isn't coming up positive. You can send serum from the dog to a reference lab to have them heat treat the serum. When they heat treat the serum, that will dissociate those antigen antibody complexes, freeing up that antigen to bind to the test at that point. Do you need to send out heat treated samples on every dog that you're testing? Absolutely not. It is best used in situations where you have the poster child for heartworm disease in front of you and you're just not entirely sure why your test isn't matching up with what you are clinically seeing. Of course, if you do diagnose the dog definitively with heartworm disease, you're going to want to follow that up with chest x-rays, and in some cases, an echocardiogram will be indicated as well. So now that we've diagnosed them, how are we going to treat them? Well, again, the American Heartworm Society has a lovely website detailing everything you need to know about the protocol for treating these cases. What I do think is a good idea to know the logic behind is, why do we need to pre-treat with macrocyclic lactones and doxycycline before we get to the point of starting that adulticide? Because owners want to get going. They know that those adult heartworms are there and they're ready to have them gone. So it can be a conversation point to say, well, we have to start with our macrocyclic lactone first. And part of why we're doing that is we want to make sure that at the time we're going to give this adulticide, it is going to take out everything that is left in the dog. So we want to make sure there are no up and coming L3 and L4 larvae that could ultimately develop into adult worms after we've given the adulticide. And then from the standpoint of the doxycycline is aimed at the heartworm nematode's most favorite bacterial symbiont, the Wolbachia bacteria. And there's two reasons why we like to give that doxycycline. One is that when you treat with doxycycline and you take out that Wolbachia bacteria, the heartworms get really sad. They fail to thrive and they begin to wither, and the microfilaria that are present are no longer able to productively develop into their later stage L1, 2, 3, et cetera, larvae. So you're kind of putting a stop on the progression of that infection. You're making those adult heartworms really susceptible to the adulticide that you're going to give. And then once you give that adulticide and they begin to break up, you actually can avoid that sudden release of bacteria that would contribute to inflammation in your patient. This is key. We want to avoid that inflammation, because during the adulticide treatment is when we really worry about the possibility of pulmonary thromboembolism. So anything that we can do to reduce that risk, the glucocorticoids that are recommended, and that strict cage rest is so important, making sure that owners understand why that is so important. And again, that after this treatment, even though the worms may be gone, the damage that they caused can be for life. They can still have that long-term persistent cough. So much better than having to actually treat heartworms is prevention, making sure that owners understand how key it is that they give them on a regular basis, because we can only take out those L3 and the L4, testing annually, making sure that anytime you are about to start a preventative that we're testing at that time, testing those puppies, making sure people understand that this is a year-round problem. So much better than actually having to treat the problem. All right, we've been through our first one. Any guesses? I wish we were in person. Any guesses as to what the number 2 vector-borne disease we're going to cover is? This one may or may not surprise you. We are moving into canine babesiosis. So how did canine babesiosis grab the number 2 spot? Well, it is the most common and widespread of all of the canine vector-borne diseases, literally on every continent except for Antarctica. Wherever you are practicing right now, there's anywhere from 1 to 3 Babesia species in your area. And we find that while they do have seasonality with tick activity in many parts of the world, in some parts of the world, their activity is going to be continuous. And we are finding, again, that these tick species and these Babesia are moving into new areas where we'd not previously seen them before. Some of that is greater awareness and testing. Some of that is because of, again, that population movement and the vector being able to thrive in new areas where it was not before. So Babesia are Piroplasms. That is a protozoal species that infects red blood cells. And there are 11 different piroplasm species that will infect dogs. We don't have clinical information for many of them. Here in the United States, the ones that we most frequently encounter are Babesia vogeli, Babesia vulpes, Babesia conridae, and Babesia gibsoni. The vast majority of dogs that are turning up Babesia positive are going to have acquired that Babesial infection from a tick. The big exception to that we think of is Babesia gibsoni, where we also think about that dog-to-dog transmission from bite wounds, as well as vertical transmission from mother to pups. For the tick transmission, the vector ticks for Babesia are 3 host ticks, and they have transovarial transmission of the Babesia. What that means is that an adult female tick that has Babesia will indeed pass that on to the eggs. And so when those little larvae hatch out, they are ready to go to infect dogs with Babesia. So 3 shots for being able to transmit Babesia to our companion animals. Babesia have one of the slower transmission times. So from the point of tick attachment to the point of actually transmitting that Babesia, it's typically in the 48 to 72 hour range, although there are a number of factors that can influence that as well. So just how bad is it to have Babesia? Well, it can go anywhere from subclinical, we don't know that they have it at all, to organ failure and death. And so with such a range, it's certainly something we want to keep in mind when we see clinical signs that should trigger us to think of Babesia as a possible culprit. Again, for an organism that likes to reside within red blood cells, we're certainly thinking of anemia as a cardinal sign. It's certainly not uncommon for them to have fever. Many of them will present with moderate to severe thrombocytopenia as well. Some of them will develop organ injury, and typically I think of renal failure, of acute kidney injury, and severe protein-losing nephropathy as kind of the key ones that I'm looking for. In truth, it'll depend on the individual Babesia species as to exactly the type of clinical signs that you're likely to see as the most prominent ones. How are we going to diagnose Babesia? Well, one of the key take-home points that I want you to have from this particular section is how important it is to try to get that PCR. And the reason that you want that PCR, the reason you want to send your samples to a good laboratory that can speciate as many of the Babesia as possible is that knowing the exact species of Babesia that you have is going to help you to choose the most effective treatment. And so yes, you might see Babesia on a smear, but you're not going to be able to know just from looking at that which treatment is going to be the best one. Same problem for serology. It's going to tell you that Babesia is likely to be there, but it won't necessarily tell you where to start with your treatment. So PCR is a good place to start. Submit that serology as well. And then while you're waiting for those results, by all means, do a good blood smear. Look for these guys. This is an artist's rendition of both our large form and our small Babesia. And this is what they would look like in real life. Something I think is important is, of course, when we're giving a talk like this, we show you these pictures that are so very obvious. You know, look at all these Babesia here. You may not see that many. Do a really careful search. Search more than once. Get different samples at different times and do repeat blood smears if you are suspicious that this may be the culprit to be Babesia, because they're just not quite as easy to find as we make it look like it certainly should be as you're looking at this slide. So remember, I mentioned that it can range from subclinical infections to all the way to death. And it's important to remember that many dogs can have those subclinical infections. So we want to be screening for this in certain cases, particularly if you have any association with a blood donor program, because it would be possible to have a dog that is infected with Babesia and you'd never know anything else about it right now. I also think it's very important if you're considering many splenectomies are not something that is optional, but if it's something where you have that time to be able to consider testing for Babesia prior to doing a splenectomy. So crucial to do that and get those results back first, because can be absolutely devastating to have one of these infections in check when you have the spleen, and then have it be quite difficult to control post-splenectomy at that point. So screening dogs with both serology and that PCR, and keeping in mind that a negative PCR doesn't mean that there's no Babesia present. Treatment for the clinically affected Babesia positive dog. Of course, there's going to be a fair amount of supportive care, blood transfusions, the importance of nutrition, and of course, tick removal. Let's make sure that they don't have any ticks left on them. But your specific anti-babesial drugs are going to be based on that species of Babesia that is infecting. So for Babesia gibsoni, Babesia vulpes, Babesia conridae, you're thinking about starting with a 10-day course of atovaquone and azithromycin. If you have Babesia vogeli, imidacarb would be the place to start. Hopefully what you will find is that as you are doing this treatment, those clinical signs are going to improve and resolve. It is not likely that you will be able to fully prove that the Babesia is completely gone. To try to have a feeling that they are completely gone, you're going to wait 60 to 90 days before repeating your PCR. And part of the reason you're waiting that long is you want to make sure that the intra-erythrocytic Babesia get turned over in terms of the red cell population, that you're not getting kind of a false positive with Babesia that are no longer alive. If you get out to 60 to 90 days, you repeat your PCR and it's negative, fantastic, but it's still so important that that dog is monitored carefully for the rest of its life and is on an effective tick preventative so that they don't serve as a reservoir for continuing to pass on Babesia. If you get to 60 to 90 days and your PCR is positive, but the dog is not clinical, you may or may not elect to continue trying to treat. In many cases, what you're really trying to do is make sure that the dog's immune system is keeping the Babesia in check. And one of the ways you're going to do that is with frequent monitoring of the CBC for anemia, the chemistry, monitoring those renal values, and the urinalysis, making sure that they're not developing severe protein-losing nephropathy. If any of those situations change, then reconsidering typically a different treatment. I usually don't repeat, for example, the same atovaquone and azithromycin a second time. I might switch to something like triple antibiotic therapy with clindamycin, metronidazole, and doxycycline for 3 months instead. So again, Babesia, moving into new areas, so important that we try to keep in mind that these can be occurring, and highly important to speciate which Babesia you're looking at. All right, 2 down. Moving on to number 3. I think number 3 is going to surprise you, but it's a pretty interesting one. We are moving into canine leishmaniosis. Canine leishmaniosis. How did this grab our number 3 spot? Well, it does have pretty good worldwide distribution, albeit North America is not one of the primary areas that we think of. We think of it in Southern Europe and the Middle East, Africa, Central and South America. And the vector for Leishmania infantum, a protozoal species that causes Leishmaniosis in dogs, and the preferred term Leishmaniasis in people, is transmitted by sandflies, kind of looks like a furry mosquito. We don't have sandflies that transmit Leishmania infantum here in North America, but they are present in Central and South America. And again, we do worry about climate change allowing these sandflies to begin to expand into new areas where they've not been previously. This particularly is important when you consider that in Leishmania endemic areas, dogs are the main reservoir of the domestic cycle, which means they are one of the primary influencers on when humans have Leishmaniasis. And if you've never seen cutaneous, visceral, mucosal human Leishmaniasis, it is the stuff of nightmares. So this is absolutely something that we want to know where it is and when it can affect our canine species as well. So again, the Leishmaniosis is endemic where the sandflies are happiest. And sandflies like things a little bit differently from mosquitoes. They like for things to be dry, no rain, no wind. If there is freezing temperatures, that is indeed lethal to these sandflies. So I'm telling you about all of this, and I'm sure you're thinking, well, wait a minute, like, do we have this in the United States at all? And indeed, you may remember we actually do. And one of the first ways that we think about it is when it became a significant problem for foxhounds. So it became rather well spread throughout foxhound kennels. And you might say, well, how did that not get noticed? But there can be as much as 7 years between the time that a dog is infected with Leishmania and the time when clinical signs are actually evident. So vertical transmission, blood transfusion can occur, and it can be an awfully long time before anyone realizes that that is a problem. And at some points, there's been greater than 20% of that foxhound population that has tested positive for Leishmania. But perhaps more recently and interesting to consider was a paper that was published just about this time last year in the Journal of Veterinary Internal Medicine, looking at dogs that were tested from 2006 to 2019 in the USA and Canada. Of 1,961 dogs that were tested, 125 of them came up positive. Only 10 of them were foxhounds. The other 115 were non-foxhound breeds. Well, where did they get it from? Well, we have travel history on 69 of them. And indeed, 60 of those dogs had traveled outside of the US or Canada. So you could say, okay, well, they probably picked up Leishmania outside of the US or Canada. But 9 of those dogs had not traveled outside of the US or Canada, and 5 of them were not foxhounds. So where did they pick it up from? Well, we don't know, and there's any of a number of possible explanations for where it came from. And it's important that, I'm not trying to emphasize that you're going to see your very first case of Leishmania tomorrow at the clinic. But I do think that this is a possible disease that could spread into the United States. And it's something that is worth knowing and worth being aware of and worth thinking about what kind of travel history our patients have, because they're traveling so much more nowadays than they ever did previously. And it can take so long from the point of infection to the point of clinical signs that it's not like asking, hey, have you traveled someplace in the last 6 weeks? This could be something that happened years ago and nobody thinks to ask about it. So what are we looking for? So we have a dog here who's depicted that has an infection with Leishmania. And to me, I think if I first saw that dog, I would start thinking about maybe pemphigus foliaceus, maybe I'd be thinking about Demodex. I certainly wouldn't be thinking about Leishmania. And so the good news is that greater than 60% of the population that is infected with Leishmania are actually going to be clinically healthy. They are not going to show clinical signs. And part of the reason for that is that they develop a very strong cell-mediated immune response. For the 5 to 10% of the population that do develop clinical signs, they have an immune response that is much more heavily antibody mediated. And what happens then is that it is not protective, and you get significant deposition of antigen antibody complexes throughout the body. And it is those antigen antibody complexes that causes the pathology that we see. So the more immune complex deposition you have, the worse the clinical signs. You can get severe vasculitis, glomerulonephritis, polyarthritis, and ocular lesions, any of a number of other clinical signs depending on where those antigen antibody complexes are. If you have a dog that was actually bitten by sandflies relatively recently, you can actually see those inoculation chancres depicted in that bottom picture there. That's where the sandfly bites. And if you were to do cytology in that region, you would see macrophages that are actively infected with Leishmania protozoa. So how are we going to diagnose this? Well, positive dogs are going to be PCR positive and serology positive. But what's tricky about this is, again, remember, the vast majority are not going to have clinical signs. So you do have to be very careful that if you test for this and you have clinical signs that match and a PCR that matches and a serology that matches, that there's still nothing else that could also account for those same clinical signs. You have to make sure that it's not a dog that is in fact clinically healthy for its Leishmania and actually does have pemphigus foliaceus or something else causing the clinical signs that you are seeing. In the event that treatment is indicated, that you say I'm PCR positive, serology positive, the clinical signs match, and I haven't found anything else that would account for these clinical signs, treatment is initiated based on the severity of those clinical signs. So very mild clinical signs may be treated only with allopurinol. As we increase in severity, we typically in the United States would try to treat with miltefosine and allopurinol. You're not aiming for a clearance of this parasite. Very much like Babesia, it's very hard to prove that it is entirely gone. What you're really aiming for is teaching the immune system to switch to a cell-mediated immune response so that it can hold the parasite in check on its own. And then very much again, like Babesia, you want to make sure that you have routine monitoring in place for these dogs because they are at risk if they were to become immunosuppressed or any other reason that they would lose that strong cell-mediated immune response of having recurrence of this disease. It's a really interesting thing to keep in mind that this could be a problem in future years. Again, probably not going to see your first case tomorrow, but important not to completely relegate it to the absolute back of the brain. All right, we're 3 through. We're going to move on to number 4. We're going to downsize a little bit. We were at our nematode. We did some protozoa. We're actually going to move in now to canine borreliosis. So caused by the bacteria Borrelia burgdorferi sensu latu, this is the etiologic agent of Lyme disease. And it is the most common tick-borne disease of dogs and people in the temperate north. And what dictates that distribution is largely where the vector of Lyme disease most likes to inhabit and where the vector's favorite hosts most like to inhabit. And in what I am guessing at this point you are gathering is a common theme. We are seeing this disease spreading. The warming climate and host ranges being able to expand are allowing the vector tick populations to move into new areas, and they're carrying that Borrelia burgdorferi along with them. In the last 20 years, the North American range for this disease has more than doubled. And some of that is because of where these ticks, where these hosts are moving. Some of the ticks are hitching a ride on migratory birds, so they're really able to expand. Some of it is because our land use is putting us in greater contact with this particular vector tick. Everybody likes those residential areas with wooded areas in the backyard, and that is all it takes to be able to come in contact with this in the right areas. So again, Borrelia burgdorferi are spirochetes. They're gram-negative, highly mobile. They're really cool. The immunology geek in me really loves this particular bacteria because they go through rather remarkable changes in their genetic expression to facilitate how they move into a tick, out of a tick, into a new host, and then how they escape the host immune response. And we're going to talk about that in a little bit more detail. Not just because I think it's cool, but also because it's very helpful to understand what vaccines are doing to target this particular problem, and then also how we differentiate a vaccinated animal from one that has actually encountered the Borrelia in real life. Now, the vector, as we know, are the Ixodes ticks, the most common vector for Borrelia burgdorferi. That's Ixodes scapularis, or the black-legged tick or deer tick, and Ixodes pacificus, the western black-legged tick. If you're super into reading about Lyme disease, you also see quite a lot of studies that are with Ixodes ricinus in Europe. That's the castor bean tick. The Borrelia are maintained in cycles that have to involve both the ticks and the wildlife. So unlike Babesia, where they have that transovarial transmission and the ticks themselves can serve as a reservoir, mama adult tick does not pass Borrelia on to her eggs. And so when those little larvae hatch out of the eggs, they are naive. They have to go find a reservoir host to pick up their Borrelia. Once they do that, they then have 2 opportunities to pass on Borrelia to dogs and to humans. And we typically think that the nymphs, which are very small, hard for humans to necessarily realize are there, are the biggest culprits for transmitting that to people, and that perhaps the adult ticks are more commonly the ones that are the culprit for transmitting them along to dogs, just because of the time when they tend to prefer to feed. They do have a relatively longer transmission time, and the risk of transmission of that Borrelia increases with tick feeding time. So there's about a 10% chance of transmission after 48 hours, 70% after 72 hours, and 90%, greater than 90%, if the tick is able to feed to completion. But there are a number of things that influence that too, including the specific species or strain of Borrelia burgdorferi, if there are multiple ticks that are feeding at the same time, if the tick gets interrupted in the middle of its meal, and if there are other co-infecting pathogens at the same time in that tick. So let's think for a moment about exactly what a Borrelia burgdorferi spirochete goes through when it is going to go into a tick. Maybe it's in a white-footed mouse, and it's going to be taken up by a little larval tick. Because again, this is really interesting for one thing, and useful to know from the standpoint of what our vaccines do. So when a tick feeds and it pulls in Borrelia for the first time, the Borrelia knows that it wants to stay anchored in the midgut of that tick until that tick moves on to the next part of its life stage. It molts into being a nymph and can then transmit the Borrelia to a new host. So they change their genetic expression and they upregulate an outer surface protein called outer surface protein A for anchoring in the midgut of the tick. And they wait until it molts into a nymph. It takes its next blood meal. And when that next blood meal comes in, the Borrelia says, hey, it's time to go, because now's when I can get into my next host. So they downregulate OSP-A. They upregulate outer surface protein C, and they cruise outer surface protein C, they cruise to the salivary glands of the tick, and that allows them to then be inoculated into their new host. So when they first get into the new host, they are expressing outer surface protein C. And then this is the part where it's kind of like the Borrelia brings along an entire wardrobe of disguises. They upregulate a protein called VLS-E, which is something that they are going to begin to change over the course of the time that they are in the host, so that just about the time the immune system is recognizing the Borrelia, it's kind of like the Borrelia puts on a little hat and glasses and the immune system says, oh, I don't actually recognize you anymore. You've changed your outer surface protein. You don't look the same. I'm going to move on. And this is what actually allows Borrelia to persist inside the host. Some of what is that VLS-E complex is the C6 protein. And so our vaccines are typically directed against outer surface protein A and outer surface protein C, and our test to determine if a dog has actually been exposed to Borrelia look for antibodies against that C6. So that's how we're actually able to distinguish between the two. Now, what is the clinical picture for dogs with Borrelia? Well, the good news is that most, about 90%, will not develop clinical signs. And this is a little different from humans who get that bullseye or kind of target lesion, which is super creepy because you're actually seeing those spirochetes migrating out from the tick bite site. That's what that lesion actually is. But subclinical disease is quite common in dogs. A little bit like Leishmaniosis, how much of pathology we see is typically associated with the type of immune response that the dog mounts. So in about 5 to 10% of dogs at greater than 4 weeks post-infection, so this is not going to be a tick that you saw yesterday, they will begin to show what are typically some fairly non-specific signs, the kind of things that I associate with almost any tick-borne disease: fever, malaise, shifting leg lameness. If you diagnose them as C6 serology positive with these corresponding signs and no other possible underlying cause for that, antibiotic therapy will help facilitate treatment. For a small percentage of dogs, they will develop much more severe, typically immune-mediated disease, such as a severe immune-mediated polyarthritis or immune-mediated nephritis, Lyme nephritis. And if you see one of those cases, you don't readily forget it. They carry a very poor prognosis and they are very difficult to treat. Again, testing, we're looking for serology positive antibodies against those C6 proteins, keeping in mind that, again, since most dogs that are C6 positive are going to have no clinical signs associated with that, that you want to make sure there isn't another possible underlying cause that accounts for the clinical signs that you're seeing in your patient before you necessarily decide to treat. Treatment is doxycycline for 30 days, 1 to 2 times daily. If you're doing the 2 times, it's the 5 mg per kg dose. You are certainly going to want to treat seropositive dogs that have clinical signs for which you can find no other underlying cause. You are also going to want to treat asymptomatic dogs that are seropositive and have evidence of a protein-losing nephropathy. Now, where things get a little murkier is, do you treat an asymptomatic dog that is seropositive and that does not have any evidence of a protein-losing nephropathy, no proteinuria? That's a little tougher. The 2018 ACVIM consensus statement was not able to reach a consensus on whether or not treatment was indicated. Those in favor say we don't know what the persistence of Borrelia may do from the standpoint of chronic kidney disease or degenerative joint disease. And so why not treat with the doxycycline to make sure we're eliminating that possibility? Those against say, we don't know that the Borrelia is going to cause any of those things, and we need to be responsible with our antibiotic usage. Regardless of where you come down on that particular issue, what they were able to receive or to achieve consensus on is the importance of using tick preventative products, making sure that owners understand how important it is to prevent this issue from coming up in the first place. And again, to be adherent, to make sure that they're giving these tick preventative products on time. Can be helpful to use an extended duration product to increase the amount of coverage time that dogs are protected. And in endemic areas, of course, considering vaccination as well to complete that spectrum of protection at that point. All right, made it through 4. We're in our last one. We are going to go big and go home, because we're going to take it home with not just one pathogen here. We're going to take out the entire group of rickettsial diseases for our 5th and final vector-borne diseases of the dog. So the rickettsial diseases are minute, obligately intracellular bacteria, mainly of the families, the Rickettsiosis and the Anaplasmataceae. And again, the distribution of where you're going to see these is going to be dependent on their tick vectors, but that gives them fairly worldwide distribution. It is very uncommon to have not encountered at least some of these diseases at some point in time. They are found in many different climates, and again, recurring theme, they're spreading. We're seeing all of the rickettsial organisms moving into new areas as their tick vectors are able to move there as well. There are both domestic cycles and sylvatic cycles of these organisms. And what that means is that for the domestic cycles, your dog doesn't necessarily have to have taken a romp in the woods to be able to encounter the ticks that can carry these diseases. So Rhipicephalus species, the brown dog ticks, are perfectly happy living in boarding facilities, in kennels, in homes. And that means that they can serve as a reservoir, that dogs can serve as a reservoir for these diseases without going out into wildlife. Contrast that with the sylvatic cycles, where you are going to be walking out in the woods probably to pick these up. That said, keep in mind that woods is a bit of a subjective term. With changes in land use, et cetera, the woods can be just the edge of your backyard, not uncommonly. In terms of transmission time, these are the ones that really push us on the importance of speed of kill of our preventative products. So transmission time can occur within 24 hours of tick attachment, and there are reports of Ehrlichia canis and Rickettsia rickettsii being able to be transmitted within 3 to 12 hours. Even Anaplasma phagocytophilum can be transmitted in under 24 hours. So these are the really speedy guys. Again, this is also a little bit of a common theme here. Many infected dogs do not develop clinical signs. There was a nice study where they took 10 healthy dogs on weekly walks through tick-infested areas, and at the end of their period of time, 10 out of 10 of those healthy dogs were serology positive for Ehrlichia species and Rickettsia species. 9 out of 10 had rickettsial species positive on PCR. 0 out of 10 of them had any clinical signs to show for that exposure. And indeed, depending on where you live, anywhere from 5 to 40% of dogs can be seropositive for a rickettsial agent and have had no history of clinical signs associated with that. So the good news and bad news about that, we certainly don't want our dogs to be symptomatic, but asymptomatic rickettsiomic dogs serve as a key reservoir. The Rickettsia species, kind of back like Babesia, they actually do transovarial transmission. So rickettsial species have a reservoir as the tick as well, but Ehrlichia species and Anaplasma species, the dog is a key reservoir for them as our wild canids as well. The clinical course of what you're going to see when you have a rickettsial infection for which the dog is going to be symptomatic depends on the type of rickettsial organism you have and what type of cells they like to bother. So for example, Rickettsia rickettsii damages endothelial cells, so you see a vasculitis. Ehrlichia canis commonly infects monocytes, and so you're going to see clinical signs associated with that. Ehrlichia ewingi and Anaplasma phagocytophilum can affect neutrophils, occasionally eosinophils, and Anaplasma platus tends to prefer platelets. In a generalized sense, for all vector-borne diseases, if I see a dog that is presenting with lethargy, soreness, anorexia, and a fever of unknown origin, vector-borne disease, and in particular rickettsial infections, start to go up towards the top of my list. The two that I worry about the most are Rickettsia rickettsii and Ehrlichia canis. These are the ones that can cause really severe disease. So I think of Rickettsia rickettsii sometimes presenting with neurologic signs, seizures, ataxia, with bleeding diatheses, epistaxis, these huge ecchymotic hemorrhages. And because it causes a vasculitis, they can actually present with hyperemia and really severe edema that can lead to necrosis. And then when I'm thinking about Ehrlichia canis, sometimes those huge lymph nodes that can make you think you actually have lymphoma in front of you instead, splenomegaly, of course, chronic Ehrlichia canis that can present as a panleukopenia, where even if you are able to clear that Ehrlichia canis, you can have the effects of that panleukopenia for months before the bone marrow is able to recover from that.